Okay, I think all the technology is working. And good afternoon, America. I'm Dr. Randy Fink here from CNY Fertility in Colorado Springs. Welcome to Fertility with Fink and Friends. Nice to see all of you. 4 o'clock straight up Mountain Time, which means 6 o'clock on the East Coast and 3 o'clock on the West Coast. Sure are glad to have you here. It's another beautiful day in Colorado Springs in our wonderful CNY Nation and across the world via internet. Oh my gosh, I see Mindy joined. Hi, Mindy. It's nice to see you. And CNYF IVF Mama, I have a special thing to say to you, Kate, there. So thank you very much. We've got Honey Pot. Hi, welcome. And the Hair Weave Master. That's a new one. I haven't seen that. Glad you're here with us. Well, Fertility with Fink and Friends is a question and answer session that we have about fertility and women's health. All the questions that you have, and if you have a question for us, please be sure to throw it our way, and we're going to do everything we can to try to get to your questions. Believe it or not, I do have a special guest here today, and I will introduce you to her in just a moment. But first, I want to give a very special shout out to my friend Kate Ingram from CNY Fertility in New York, who made me this absolutely wonderful shirt that I just have to show off. Isn't that awesome? So Kate is, her handle on Instagram is CNYF IVF Mama. CNYF IVF Mama, and she can make you a shirt that says anything you want, but she has all kinds of great creative ideas, and she was kind enough to send this to me. Kate, thank you so very, very much for that beautiful gift and for all that you do for all of our patients. CNYF IVF Mama. That's Kate Ingram and her great skill set. So let's see here. I want to introduce to you my special guest and step right in here, won't you? This is my dear friend and colleague, Ena Osmanovich. Ena, E-N-A. So it's Ena, it's not Elba, it's not Emma, it's not Enya, it's not eBay. We've heard her called eBay before. Yeah, she's been called a lot of things, some of which we can't say on this family sort of program. But Anna is one of our wonderful nurses here in the CNY Colorado Clinic. And so, Anna, what is the clinic? What exactly is that? What does that mean?
So it's kind of where you get all of your monitoring done. So we'll always see you for your blood work and your ultrasound at the clinic. And then we'll also get done all of your IUIs, the HCG washes, the SIS.
So since so many of our patients here in Colorado come from global, they come from all other places, many other places. I guess the other CNY offices also have clinics just like we do. So some people get their monitoring in Syracuse, in Albany, in Buffalo, in Atlanta, and Sarasota, very soon in Orlando, some folks in Miami. We all have the same kind of clinic, is that right?
Yeah, for the most part, we all kind of function the same way. And all kind of do the same type of things. I guess that our scope of practice, like as nurses in different clinics, is a little bit different. So there might be some nurse practitioners doing kind of what we do here in Colorado out in New York, but it's all essentially kind of the same thing.
Okay, fantastic. Well, so now you know what the clinic is. Many of you do your monitoring in outside facilities in other parts of this great country of ours, of our CNY nation, as I am fond of saying. But you do have the opportunity to do. We have a lot of folks I know who will come to one of our localities, rent an Airbnb for a couple of weeks, and do their cycle monitoring in-house. So instead of being monitored by the global team, they're monitored by the local team. How many nurses work with you in the clinic?
Yeah, so we have 4 nurses in the clinic. We have 3 of our medical assistants as well. And then we also have 1 new nurse practitioner that's going to be downstairs in the clinic with us as well.
All right, fantastic. Well, let's start to hit some questions here that are already coming in. Hi, Amy Marie on the Facebook side. By the way, if you're just joining us, Fertility with Fink and Friends, we've got Facebook YouTube and LinkedIn right here. We've got a couple of different Instagram feeds. And so we're looking all across social media and just glad everybody is able to be with us here this afternoon. So the first question comes from Amy Marie. Is it practical to get IVF for someone who has had a tubal ligation? So of course, a tubal ligation is a surgical procedure that you do when you are done with your childbearing. Of course, life being what it is, sometimes our plans change. And once the tubes are tied, as it were, it means basically what we're doing in that scenario is to create an obstacle so that sperm cannot meet egg. And that's a form of permanent sterilization. One option is to try to have surgery to remove the obstacle. Sometimes we will take out a piece of tube. Sometimes we'll put a clamp on the tube. Sometimes we will remove the entire tube. So certainly if the entire tube is removed, there's very little that we can do to try to restore fertility using the tube. But surgically, if there's an obstacle that's created in the fallopian tube, we can sometimes try to remove that obstacle and reattach the tube. That is done fairly routinely in our New York facility in Syracuse. Dr. Kiltz is an expert when it comes to tubal reanastomosis, which means putting the tubes back together. But even when you put the tubes back together, we still may have a scenario where there's a blockage in the fallopian tube such that sperm can't meet up with egg. So some people opt for, rather than having surgery to try to correct that tubal blockage, we bypass the tubes entirely with IVF. So is it practical for someone to have IVF who's had a tubal ligation? The answer is yes. That is the way that you are going to get pregnant without having to do some surgery on your tubes in order to reconnect them. So how does IVF work? We give you medication that revs up your ovaries in order to give you to produce as many eggs as we can get, which we then retrieve from the ovaries under a little procedure in our office with a little sedation. It's a vaginal ultrasound guided procedure that's called a
HSG.
No, a retrieval.
Oh,
when we're retrieving, that is a retrieval. Eggs go to the lab. We have partner sperm. Sperm goes into the eggs. That creates embryos, which we can then place back inside of you after growing them up for a certain amount of time. And that's called the embryo transfer, right? So the transfer is when we place the embryo back, and hopefully that embryo sticks, and then you're pregnant. So is it practical after a tubal ligation? Not only is it practical, highly recommended, because our success rates with IVF are extremely high, and generally speaking, probably higher than that of a surgical intervention to try to reattach tubes. Amy, thank you for your question there. I saw a good question over here, and this comes from Bales 2. When do we recommend doing a PRP wash? And it's having had a history of a very thin lining. So what is a PRP wash?
So that is when we grab a couple of tubes of your blood, we go ahead and get it spun in our lab, and then we go ahead and inject it back into the uterus, and then it is going to be, that's the PRP wash, and that's going to go ahead and help go thicken your lining in that beginning part of your FET. So typically I like to recommend it to my patients when they're on that estrogen before they get that progesterone started, to help and thicken their lining.
PRP is platelet-rich plasma. And when we take some of your blood, we're able to separate out that portion of your blood that contains what we call your tissue factors, your growth factors, your healing factors. It's probably the most soothing part of the blood we can get, which we then take and can use in any number of ways. PRP is used to regrow hair in people's on the scalp. PRP is used in orthopedics and sick joints. It's used in aesthetic medicine. It can be used with filler. There's something called a vampire facial that uses PRP. So PRP is very healing tissue. We can actually put it into the ovaries in the case of a diminished ovarian reserve to try to improve egg quality. But the PRP wash is when it's placed directly inside the uterus. Is that something that hurts?
There could be some cramping. So what I always kind of mention to my patients is the uterus isn't so used to having so much fluid in there. So you might experience some sort of cramping in that process and maybe like the rest of the day. But of course, only a small amount of fluid kind of stays in. It's gravity, so what doesn't kind of stay up there will come out, but you will experience a little bit of cramping, but nothing worse than like a period cramp.
So it's not torture.
It's not torture at all.
So you place a speculum like a pap smear.
Okay.
You have a little straw that you place inside through the cervix or the uterine cavity. And do you literally just push the syringe of fluid to the inside?
Exactly like that.
Okay. Well, there we go. So that's intrauterine PRP, and that's something that is offered at all of our facilities. So if that's something that you have an interest in, please do ask us about it because we're happy to be able to offer it. I do want to say something here about, here's a question that came from, it looks like Andrea. It's a question about Zymot, and we've talked about Zymot before. Zymot is a sperm preparation device that is used in the laboratory that helps our embryologist and andrologist select what is theoretically the best sperm. So it's a device that is designed to act like the fallopian tubes where sperm can swim through, and theoretically the ones that make it to the end are going to be the strongest sperm. The evidence on Zymot is not super. I tell people it's about I think it's a $200 add-on. Is that any idea?
I think that sounds right.
Yeah, I think it's a $200 add-on. It's not a $2,000 add-on. So, if it's something that you're interested in, we can certainly do it. What I've seen from Zymot is that it does decrease the miscarriage rate, but as a result of decreasing a miscarriage rate, it decreases the overall pregnancy rate because some pregnancies will unfortunately end in miscarriage. So Zymot is not something I feel very strongly about, and much of the data, much of the evidence on Zymot is still really considered to be experimental. It's something we're happy to offer. It's at an affordable price point, so it's not out of reach. If it's something that you would like to do, then by all means do it. Andrea's question here is also, what about calcium activation? And that's something that they probably ask, you probably hear in the clinic sometimes. That's something that's called calcium ionophore. Calcium ionophore. And you may see that on social media, people talking about it. Calcium ionophore has a very specific use in the fertility laboratory. And it is typically for eggs that do not easily fertilize under normal circumstances. So it's an add-on that can be done chemically with the sperm in the eggs, designed to improve the odds of the sperm being able to fertilize the egg. When we use calcium ionophore, we have to know about it well in advance, like at the beginning of a cycle, because it takes some time for us to get it in hand. We don't always keep it in-house. We can't keep it open because it has a limited life on the shelf. So every time we use it, we have to order it in. If you've read about this and it's something that you would like to add to your cycle, then talk to us about it, because it may not be something that's necessary. As I say, it has a specific indication, but it is something that we need to know about well in advance to use it. I see Brandy over here on the Facebook side, who is 35 weeks pregnant. 35 weeks pregnant from IVF. Congratulations, Brandy. That is just fantastic. We are so happy for you. Forever grateful. Well, we are grateful to you. You developed gestational diabetes. Gestational diabetes is a situation in pregnancy where the has to do with the hormones of your placenta and the way the placenta changes your body's ability to process carbohydrates. So just like type 2 diabetes or an adult onset diabetes, it's very similar. It has to do with insulin resistance. And there are a lot of folks who go through IVF who have insulin resistance. And so that may be part of the correlation there. With gestational diabetes, typically you start out by treating that with diet alone. And then oftentimes you end up adding medications, sometimes even using insulin. What is the risk of having gestational diabetes? Well, as your insulin levels get higher, insulin is actually a growth factor. And so if you're being served with growth factors while you're growing your baby inside, your baby can also grow big. So we see the condition that's called macrosomia. Macro means big. Somia is referring to the head. Babies with big heads, big babies are born to moms with gestational diabetes. And so that's really one of the risks. But Brandy, my gosh, we're so happy for you. And I can't wait to have your pictures on our bulletin board here in Colorado. Amy's asking about what does the PRP wash cost? And I have to tell you, unfortunately, I am really out of the loop on that one. I'm not sure if you know.
I believe that everything's kind of written out in like the CNY. We have a handbook on the website, and I think that the prices are listed on there. Don't quote me on this. I want to say that it's around $300, but that could be wrong. So I would say definitely check like the fertility guidebook that's on the CNY website.
So if you're a patient of ours, on your in your patient portal, there is a financial welcome packet that generally reviews all the costs, everything that's involved with the pricing. And actually on the CNY website as well, pricing is really put out front there. And I have to tell you that in the fertility arena, that is really something that's very special, to have all that pricing up front, put out there in public. Many fertility clinics don't put that pricing up front, and there's lots of surprise costs that crop up. So I'm very proud to be a part of an organization that doesn't hide its pricing and really makes this kind of care affordable to everyone. So here's a question from Sally on the Facebook side who's asking about ovarian PRP. Can I do my ovarian PRP before my retrieval in Sarasota? Well, so far, Sarasota does not have the ability to do that yet. We can make PRP for intrauterine PRP, but generally speaking, the intra-ovarian PRP requires anesthesia. So you get a little sedation through the vein, and we're able to place that PRP directly into the ovary very comfortably. I suspect that we will soon be able to offer that in our upcoming Orlando facility, and I don't know that 100%, but the wonderful doctor in Orlando, whose name is Dr. McNichol, will, I believe, be able to offer intra-ovarian PRP. So for those of you who would otherwise go to Sarasota, Orlando's not too far. Is it okay to continue with ovarian, this is saying ovarian blooming when we have our period? Are you familiar with ovarian bloom, the supplement?
I am. I know that it's very commonly recommended, and you should be able to continue it throughout your period and some stem cycles.
Yep. Ovarian bloom is a supplement that is available through the CNY website. And think about, a flower blooming. We want you to think of your ovary in that same way. For folks who have diminished ovarian reserve. Ovarian Bloom is really a wonderful supplement that's designed to bring out the best of your egg quality and to help us to be able to stimulate as many eggs as possible. So can you continue using it? Yes, you certainly can. Buddha B. Oh, I like that name. Do you need to take off work on the day of an IUI?
Good question. And I think that Dr. Kiltz also kind of talked about like the facts and myths about transfer day and like not moving versus like going about your day. Same thing kind of with IUI. It's not one of those things where we're going to tell you we're going to do the IUI and you have to keep your legs up all the way, stay, so because gravity and all this stuff. You can kind of continue with work. I would say just something like minimal. Don't be lifting stuff that's too heavy. But I always also say it kind of depends on what your mindset is. Because if you're going to go into this and you think working that day is going to make or break, what's going to happen at the end of it, then don't go into work that day, because I don't want you to blame yourself later because you went into work. So if you feel like you want to stay at home, you can stay at home. But totally up to you, kind of.
Now, as one of our clinic nurses, I will tell you that Enna is our one of our IUI masters.
Thank you.
Does IUI hurt?
IUI, no. I always say kind of like the worst part's the speculum, honestly, at that point. It might be a little bit uncomfortable, but nothing crazy.
And when you do IUIs, how does that process work here in Colorado? Where is the sperm actually prepared?
So the sperm is actually prepared in our andrology office. They go ahead and kind of spin it for us, get it ready. The nurse walks up, gets your sperm, confirms with andrology that it is, in fact, the sperm that is going to you. Then we bring it down, get it ready. Same thing with a catheter. Go ahead and kind of pull the sperm into the syringe. And then we'll use that same catheter that we pulled the sperm up to go ahead and go through the cervix into the uterus to inject what was in that syringe.
How long do people have to lie there before they can get up after an IUI?
We do recommend laying down for about 10 minutes after.
So 10 minutes, that's not terrible. And I always say with sperm preparation for IUI, we're able to select out the best, the strongest swimmers, the best looking, the best senses of humor, right? That's what they do?
Exactly.
Yeah, we have a very special instrument in the lab that selects for sense of humor in sperm, but we only have it in Colorado. I'm just telling you, they don't have that in New York. Well, let's see what else do we have here. This comes from Heidi Klink. Hi, Heidi. Is glad to see you. If all eggs are mature and they all fertilized, and then the transfers were not successful, is it more important to focus on the egg quality for another retrieval, or does the sperm need improvement too? Okay, well, that's a really good question, because one of the things that we really try to sort out for you is, where is the issue? Now, usually if it's a sperm issue, we will be faced with a situation where the eggs just don't fertilize. There may be a fertilization issue where maybe you have a bunch of eggs that are mature, and then we try to fertilize them, and then the next day we come back to see exactly what fertilized and find that, wow, lo and behold, none of them did. That to me generally sounds like a sperm issue. Whereas if you made good embryos, but the transfers themselves were not successful, that makes me think that there is an embryo factor, that there may be something with the chromosomes in the embryo, because as we know, the most common reason that IVF doesn't work for people has to do with the chromosomes. It has to do with the DNA that's in the eggs that's being meeting up with the sperm that's creating the embryos. Now, there is some new testing that's part of an expanded form of PGT. Let's remind them what PGT is.
So PGT is the genetic testing that you can get done on the embryos, not to be confused with the genetic testing that we offer to our patients. The PGT testing takes a little piece of the trophectoderm. Is that correct?
Mhm.
We send it off to a lab, and then that lab will tell us if everything is chromosomally euploid or aneuploid, and then also let us know the gender. That is PGT-A. And then there's two other ones, PGT-M and then PGT-SR.
So the PGT testing is a great resource to be able to take a large number of embryos and help to select out which of the embryos are going to be more likely to get you pregnant. Because when we have a euploid or a chromosomally normal embryo, that gives us our highest probability of success with IVF. We were just visited by the laboratory that does our PGT testing. It's called Cooper Genomics. And Cooper Genomics discussed with us that there is now some testing that can be done that can identify the source of the abnormal chromosomes in an abnormal embryo. So we expect that some embryos are going to be abnormal just because that's nature, because we're humans and we don't all make normal embryos every time. But that testing, that expanded form of PGT testing, can now show us where did the chromosomal abnormality come from? Because classically, we have presumed that to be an egg issue, but you're right, sometimes it may be a sperm issue as well. We're now able to tell that when we test embryos. So thanks, Heidi, for that question. Do we typically, with our preconception labs, this comes from ARATH 10, hi, do we typically do FSH and estradiol on our preconception labs, or is that just at the beginning, at the baseline of our cycle?
So we have our preconception panel, which includes, all of our baseline hormone levels, but it also includes a lot of other labs added to that. We don't always repeat all of the labs. So typically we try to get all of those baseline hormone levels in a specific cycle period. So like cycle days 2 through 5, we'll typically draw your estrogen, progesterone, LH, FSH, TSH, and your beta. So we'll do that in your preconception panel, and then we'll also do it in your retrieval cycle. So whenever you start any type of cycle with us, you'll always get those labs drawn between cycle days 2 through 5.
So it used to be that we would say, oh, you have to do those preconception labs on day 3 of your cycle. A day 3 FSH, that was very, very important to us. Nowadays, we know that the AMH level, the anti-Mullerian hormone, which is the test of ovarian reserve, that gives us some qualitative information about how your body is going to respond to IVF medications. When we draw that test, it's cycle independent. It can be done at any time during the menstrual cycle. So no longer are we as concerned about having a day 3 FSH. The preconception labs, typically, I do want to see where your FSH and your estradiol level are, but it may be done really at any time during your cycle. So thank you for that question there. It looks like I can't see the name there, but if I choose to stay in Colorado during my whole cycle, how long do you recommend staying? I recommend moving here. What about you?
Same.
Same.
Just come.
So yeah, Anna's got some room, and we always have some space in the storage room a couple of doors down from my office here. So you're welcome to just stay. Generally speaking, what do you say for if you are gonna? So what a lot of folks do is that they will do their baseline testing at home. So you get your period, you do your first set of blood tests and your ultrasound where you live, so that we can see that yes, this cycle is going to be a go. How long does the stimulation portion of the cycle typically last?
Typically about 9 to 11 days is kind of what I see. Obviously, there's patients that can go less. There's patients that can stim a little bit longer. I would say it's kind of a 2-week cycle or stimulation period, give or take.
So most people who do, as Anna's describing, will stay here for about 2 weeks. There are lots of Airbnbs, not just here in Colorado Springs, but kind of around all of our facilities. So most folks who come in will stay for a couple of weeks. Then some of it depends on, are you going to do a fresh transfer or are you going to do a frozen transfer? And then obviously that extends it out a little bit longer. But so sort of consider the stem portion of the IVF really to be like the first half of a menstrual cycle until the point that you might otherwise ovulate. Looks like Jen Mullaney is asking, what would be the best protocol for ovarian reserve? Well, I'm not sure what you mean by that. We have some special protocols that we think about for folks who have diminished ovarian reserve, and otherwise we have protocols that are kind of based on age, based on your anti-Mullerian hormones. So it really is very individualized. It's not a one size fits all, and it's not something where we can take something random and apply it to everyone, because everyone is going to respond differently. And of course, each individual who walks through our doors is an individual, and we expect to respond in their own manner. So we'll figure it out, though. That's what we do here. So let's see what else we have. What type of stems or IVF would you recommend for a 41-year-old with diminished ovarian reserve? And that's a great question. It looks like it's coming from 12081. Hi, glad to see you on the Instagram side. Anna, tell us what's a mini dose protocol?
So a mini dose protocol includes letrozole, which is going to be for 5 days. There's some tablets that you're going to take. And then that's about 10 milligrams daily for 5 days. And then your FSH would be around 200 units. And then your low dose HCG would be 20 units. That is, I don't want to say too much, but we see a lot of that sometimes, though it can help with cost of meds, because meds can be very expensive. So a lower dose, but with, the extra help of like letrozole and stuff like that, can kind of help to lower costs, but also kind of get a good response.
Anna brings up a great point, and it makes me want to tell you about the classic wisdom in IVF, and it's a bit of the older way of thinking, was that in someone with a diminished ovarian reserve, that we want to pour as much medication as we can get onto those ovaries to try to get you to respond. We want to give you as high a dose as we can get in hopes that we're going to get some response from that ovary that may have a diminished reserve. The problem with that is, as Anna said, cost, because we all know those medications are expensive. And when we use high dose medications, sometimes what happens?
You know what they say, like, too much is sometimes not a good thing. So
we may not get a response at all. So sometimes the ovaries will just kind of shut down because they don't know what to do with all that stimulation. So what we've learned, really much of this experience coming from Europe, is that where the governments pay for IVF, but the governments also tell you, these are the doses that you're going to use. And you're going to use these very small doses because we're paying for it. We don't care if you get 20 eggs or if you get 2 eggs. We're paying for it. You're using what we tell you. They use very low dose protocols. And what we've learned from that experience is that folks tend to get a very similar outcome to their cycles when using a mini dose compared to the very high dose. Now, with a high dose, you might have more follicles, but in terms of the number of eggs that you retrieve or the number of embryos that you ultimately make, those are really very similar, but with a much lower exposure to medicine, which means lower side effect profile and lower cost. So we're fans here of low dose protocols over very high dose protocols. And so that's generally what we recommend for folks with diminished ovarian reserve. So 12081, Thanks for that question. Hey, D. Hodge wants to know, how do we handle ovarian cysts before an IVF cycle? And I was having this conversation today about ovarian cysts, and I think this is a good time to just kind of bring it up. People think of ovarian cysts, quote unquote cysts, as something that are not normal. Well, if you have a period every month and you are not on a birth control pill, some hormonal birth control, then pretty much you are forming a cyst in your ovary every single month. Now, as a gynecologist, a very common source of a common reason for referral into a general GYN or OBGYN practice is someone who's been in an emergency room with a cyst. And what's often happening there is that there's something in the pelvis that's causing pain. It may be the bowel. The bowel occupies a significantly larger amount of space in the pelvis than the ovaries do. So we feel the bowel really an awful lot more. But something has caused some pain that sends somebody to the emergency room where they get an ultrasound or a CAT scan, and maybe it shows an 8 millimeter or a 12 millimeter cyst in the ovary. And the folks in the ER say, well, that's what's causing your pain. You have an ovarian cyst. And then that woman ends up writing down on her medical history that she has a cyst, that she had a cyst, and that cyst is forever a part of her medical history, when really what they were looking at was just an ovarian follicle. It was just an egg in the ovary that was trying to develop itself to the point where it could be ovulated, because every single month in someone who has a period, that's what happens in the ovary. Now, some people do get cysts that cause them problems. Cysts can get big, and they can stretch the capsule of the ovary, and that can cause pain. Cysts can leak some of the fluid out, and that can cause pain. Those cysts can sometimes even rupture or break open. More commonly, what we see is that the ovary releases the egg, and then the space behind it fills with blood, and that's what's called a hemorrhagic cyst. And that's literally a bruise on your ovary. And so is it any wonder that that's painful? Yes, absolutely. So while sometimes the emergency department tells you that you have a cyst and it makes you think that there's something that's wrong with you or wrong with your ovaries, in many cases, this is just a part of the normal physiology of the ovary, simply the way the ovary normally works. Now, when we're doing IVF, sometimes we do see a cyst at the beginning of the cycle. What does that look like when you look with the ultrasound?
So as we kind of talked about before, each baseline monitoring appointment, we're doing that ultrasound between cycle days 2 through 5. So at this point, you already had a period. When we're looking at the ovaries, we're looking for them to be quiet. So we don't want to see any, follicles or cysts or anything like that going on. So when we do see that, it could be kind of anything like, I would say, bigger than 14 millimeters. And it could be either hormone producing or not. And that's something that we kind of need to wait on your lab work for.
So what happens is we see it there, we check the blood, and when the blood test comes back, that gives us a little bit more guidance. So sometimes if there is a large hormone producing follicle in the ovary, that may affect the way your body is going to receive the medication that we're using to stimulate your ovary for IVF. And in that situation, sometimes we may suggest that you wait. Sometimes we will try to maybe put you on a little bit of hormone to quiet the ovaries down and let that cyst resolve itself. Sometimes we can even place a little needle inside that cyst and suck the fluid out so that when you do the stimulation for your IVF, that it won't affect. But that's something that we do see pretty commonly. And in fact, if you've ever been told that you have a cyst, I want you to know that whether it's a part of IVF or whether it was something that was causing you pain, in all probability, it was part of your normal ovary. So I don't want you to worry that something is wrong with you if someone told you you have a cyst. Now, there are some cysts that are abnormal. Sometimes cysts can grow very large and can be differing kinds of growths in the ovary. So that's why it's important that we evaluate these things and that your own OBGYN follow you and keep track of if it appears that you have some large cyst inside the ovary. So let's see, I think we've got some other questions here. It's about 40 minutes or so after the hour. And if you just joined us, you're with Fertility with Fink and Friends. I'm Fink, that's Friend. This is Anna. Anna, where are you from originally?
Originally from Bosnia.
Bosnia.
Yes.
Wow.
Yeah.
So do you speak any other languages?
I do. Bosnian, Serbian, Croatian. It's all the same language, but it's called three different things.
Wow. And so when did you come to the United States?
So I was about 2 years old when I came to the U.S. Lived in Colorado ever since.
And so did you learn the language because your family speaks, or?
Yeah, so it's primarily in my household and with my family. It's all Bosnian.
Wow. So Croatia has wonderful beaches, right?
Yep, they stole all of ours.
Okay. Well, there's no bias there, so we will move on. Boy, it got really awkward just now. Hey, Judy joined us from Miami. Hi, Judy. Nice to see you. Let's see what we have here. It looks like I'm having a hard time seeing my little phone over there, so sorry, but hello. I haven't had issues with fertility, but had my tubes completely removed in 2016, and now would like to add to our family. How likely would IVF work? That is exactly the sort of scenario that IVF is perfect for. So I would say, well, you don't have fertility problems except that you don't have fallopian tubes. And so that kind of means that there's an issue there, but same process. We get some eggs from you. We place some sperm inside, we make some embryos, and we place an embryo back. Hopefully that embryo sticks. That's the perfect indication for someone to do IVF, because in the absence of those fallopian tubes, there's no way for sperm to be able to meet eggs. So it looks like I can't see if that's Julie Lee or Julie. Hopefully we can be of some help to you. Let's see what we have here. It looks like my husband, that's coming from Fall Marsh. I'm not so good at reading the little names there. I wish they would make. You know what? I'm showing my age because it's my glasses. That's the problem. I can't see it. My husband has slow sperm. What could help to get pregnant naturally? Well, slow sperm. So I presume that means he has had a semen analysis. Do we do semen analyses here in our office?
We do, yeah. We do the whole everything. Andrology does do the semen analysis, and you can always get that scheduled with us.
So a semen analysis can be collected either here in the office, or there are means of collecting at home and even sending to us. So if there's a question about sperm, I think it's certainly worthwhile to know. So slow sperm could mean something about motility, which means how many sperm are swimming. There's other things that they look at with sperm that they call the forward progression. How many of those sperm are swimming forward? They talk about sperm counts. They talk about something called sperm morphology as well. Are you familiar with morphology?
Yes.
Morphology means kind of what do the sperm look like? So there's someone whose job it is to look at sperm under a microscope and to tell us doesn't have a normal head, doesn't have a normal tail, doesn't have a normal neck to it. Morphology is something that we look at as well, even though technically speaking, abnormal morphology is not considered to be a cause of infertility, but rather it has some association with subfertility, or people who are having a difficult time. So slow sperm, not quite 100% sure what you mean there, but there are supplements that are said to improve sperm. There is a book that I would recommend, and I do recommend to anyone who's thinking about going through the IVF process. And that's a book that's called It Starts with the Egg, which is really a great resource. It is it's researched and has citations in it. Unfortunately, a lot of times the things that we read, say on the internet, for instance, or the people like us who talk on social media may not always have the right information. And books, sometimes when you read a book, so just you probably know that a textbook, by the time it gets to be published, is already really behind the times, obsolete in terms of the information that's in it. But It Starts with the Egg is a good book, and there's actually a very nice little chapter on sperm and how to improve sperm and some different supplements that may be helpful for improving sperm. Hey, a special shout out, if I can, on the Facebook side to Dr. Banerjee, who is watching us from wherever Dr. Banerjee actually is. Sometimes he's in New York, sometimes he is in the Washington metro area in Maryland. Sometimes he's even here in Colorado Springs. So Dr. Banerjee, we're glad to, honored actually, to have you watching us. Deanna on the Facebook side is asking about endometriosis. Does endometriosis and cleaning out endometriosis help with the success rates of IVF? And the answer to that is
yes.
Yes. The answer to that is generally yes. Now, there are some people who have endometriosis who don't have any problem at all with getting pregnant. And what's interesting is that there's sometimes that we'll go to do surgery on someone for some other reason. Maybe it's taking out an appendix or looking at a gallbladder or doing something that we happen to look and see that she has a tremendous amount of endometriosis and she had no idea it was there. Whereas some people who are clinical suspicion is very high that they have endometriosis, when we go to look to try to help them surgically with a laparoscopy, we find that there's maybe one little spot or there's a very minimal. So what we see when we look doesn't always correlate with how you feel. And the classic wisdom with endometriosis is that what you see is only the tip of the iceberg. So if you're having a difficult time getting pregnant and endometriosis is pregnant, oh my goodness. Oh, you're laughing at me now, right? You can't get good help these days. If you're having difficult time getting pregnant and you have endometriosis, then excising or removing that endometriosis is recommended. Now, we do have a non-invasive test for endometriosis now, and it's called
the Receptiva.
Receptiva. How does the Receptiva test? How is it performed?
So typically, it kind of looks like a medicated FET cycle, so a medicated transfer cycle. You'll get on, some estrogen and then some progesterone, and we'll time the biopsy. The biopsy is a speculum. We go ahead and go in with a catheter. It's like a pipette. We try to get that pipette all the way to kind of like the wall of that uterus, and then we take out a biopsy of that wall, and then we send it off to the lab where they can check for those endometriosis markers.
So the marker is actually called BCL6, if you want to look it up, because I'm sure there's something on the internet about it. BCL6 is a marker of inflammation that has a very high correlation with endometriosis. And so at a particular time during the cycle, so as Anna mentioned, we often do it during a medicated cycle like it was an embryo transfer, or it can simply be done 7 to 10 days after you have ovulated. So it's in the second half of the cycle, or what we call the luteal phase. We do a little biopsy, little straw goes in through the cervix. We suck a little piece of tissue out, and they can test for BCL6. And if it's positive, the data shows us that either surgically removing some endometriosis or treating you with medication for, on average, about 60 days prior to doing an embryo transfer does improve your chance of success. So one way or the other, if we think there's endometriosis, Let's find out. Question here from one of the Instagram sites from Kylie Ann Diaz. Hi, Kylie. Does the chance of a successful embryo transfer increase with each new cycle? And how many cycles does it take to get a successful frozen embryo transfer? Well, we know that the IVF, when we're doing a retrieval, right? The retrieval, if we do what's called stacked cycles or back-to-back cycles, it's almost like your body knows what to expect. And so with each successive cycle, you tend to do better, if not in numbers, at least in terms of egg quality, because the medication that you use during the first cycle will continue to help you recruit eggs for subsequent cycles. But once we're putting embryos back inside, it's really just a factor, I think, of the embryos that we've made. So repetitive embryo transfer cycles don't necessarily increase the probability like repetitive retrieval cycles improve the outcomes for eggs. Now, as we do more transfers, we get more likely to come upon an embryo that you've created that's chromosomally normal. So that's why we say, IVF is a numbers game. If at first it doesn't work, we do want you to try again. It's unusual when we can do a single transfer and someone gets pregnant. It happens every single day, but the expectation is it may take more than one. So Kylie, don't be frustrated with it. And this is certainly a very frustrating process to have to go through. But I will tell you, as evinced by the number of wonderful people who are watching this broadcast today, you are not alone in what you're going through. There's probably nothing that you can experience, no matter how bitter or how happy or how frustrating or how many tears you may have to cry. There's probably a lot of people out there who have experienced the very same thing. You are not alone in that. And I strongly encourage all of our viewers to reach out to this wonderful community and to be involved in this wonderful community, because you may not always get good medical advice from non-medical people, but you get good spiritual advice from people who have great spirits. And I really can't speak highly enough of our CNY patients. Kylie, I hope you don't lose faith. So thanks for that question. We've got a few more minutes here for a few more questions. Do we, and this comes from, looks like Ms. C.R. Tyler is what I think that says. For a patient with diminished ovarian reserve, Menopur versus HCG-LH, and we use both. What do you see being used more?
Well, as of lately, I've been seeing a lot more Menopur. The HCG-LH is a little bit more cost effective, though.
So I agree. HCG as an LH medication is definitely less expensive. There are many people who would tell you that there is no difference. I think there probably is a little difference using Menopur. Menopur is a medication that's called human menopausal gonadotropin, and it actually comes from the urine of menopausal nuns in Italy. That's a fact. That is a fact. It sounds like a joke, but no, it's not. That's actually where the medication comes from. So, you can imagine that the process that it takes to extract that is labor intensive, and so the medication is costly. But I do think that if we've had a number of cycles where we haven't been successful, switching to Menopur is a reasonable thing to do. Many practices in the United States use Menopur as the first line drug. In trying to keep our costs effective and our costs in control, we typically will start with HCG as LH, but sometimes insurance will cover the medications, and if that's the case, then certainly go right to Menopur. Let's see if we can get one more in here, and then I want to say, and then I want to have a little something to at here. Oh, Brandis says, yep, she loves that book. I think we were talking about it starts with the egg. By the way, if you are not a member of, oh, and Amber is here as well. Hi, Amber. Oh my gosh, look, and everybody from Miami. We've got all my friends here. So thanks everybody for being here. If you're not following along my Instagram, it's Randy Fink MD. Please also look at Brandis Courtney. Brandis is going to be starting on her egg freezing journey and is going to chronicle that through Instagram. She is a wonderful resource and is great to have around here. Your Instagram is where you put pictures of your dog. So, and there's no problem with that because what kind of dog do you have?
I have a boxer.
And he's a beautiful, beautiful
Yes.
dog. And what's his name?
Pasha.
Pasha. Well, that is a great thing. I want to throw a special hello. Step right in here. Milton, yeah, come stand right behind us here. I mentioned Dr. McNichol. This is Dr. Milton McNichol from Orlando, who is visiting with us here in Colorado Springs this week and is going to be his very successful and very experienced office in the Orlando area, I believe is going to become part of the CNY family. Is that?
We're looking to join, absolutely so.
Well, so if you're in Orlando, that is Dr. McNichol is the man to see, and we will look forward to having you more in our lives. And speaking of in our lives, we're going to be wrapping up our live for today. A special thank you goes out to the wonderful nurse Inna Osmanovich. Thank you for being here with us. Thank you for all the work that you do in our clinic for our wonderful patients here in Colorado Springs.
I wouldn't want to be anywhere else.
We get such great feedback from our nurses here, and I hope all of you will have a chance to experience some of the CMY hospitality. If not here in Colorado Springs, then in Syracuse, in Buffalo, in Albany, in Sarasota, in Atlanta, in Miami, all these places and more, and that you'll join us next week also for Fertility with Fink and Friends. Every Tuesday, 4 p.m. Mountain Time, 6 p.m. on the East Coast. So I'm going to say thanks to everybody for being with us. Let us help you with your family because that's what we're here for. God bless you all. Thanks and have a good night. Okay.
You guys did a good job.
Wonderful.
Thank you. Hold on here. We just have to end over here. All right, we're still here, but we're trying to get out of your hair.